Thank you, David. It's great to be here. I'm very much looking forward to the day, and I have the honor of introducing Harvey Fineberg, who is president of the Gordon and Betty Moore Foundation, and he's previously served as president of the U.S.'s Institute of Medicine, which is now the National Academy of Medicine. He was the provost at Harvard University and also served as dean at Harvard Chan School of Public Health. But what's more important to the SMDM community, and we are very indebted to Dr. Fineberg, is that he is one of the founders of the society. He also, interestingly, chaired the second annual meeting of the society in 1980 that was hosted in Washington, D.C., not virtually, live. He was also the president of our society in those early years. He's devoted much of his academic career to the fields of health policy and medical decision-making, and his research areas have included global health, the assessment of medical technology, evaluation and use of vaccines, and dissemination of medical innovations, all very much part of the community that's gathered here today. He's authored many books, including Clinical Decision Analysis, Innovators in Physician Education, and The Epidemic That Never Was. Interesting at this moment to think about that. That was an analysis of the controversial US immunization program against swine flu in 1976. But turning to this year, in the midst of the pandemic, his background currently with the National Academies of Science, Engineering, and Medicine is that he's appointed to serve as chair to the Standing Committee on Emerging Infectious Diseases and the 21st Century Health Threats. This standing committee was formed at the request of the White House Office of Science and Technology Policy to assist the federal government with its response to COVID-19 and is very busy putting out answers to many requests. He also wrote an optimistic article for the New England Journal of Medicine in April entitled 10 Weeks to Crush the Curve. We are now interested in knowing what Harvey is thinking and having him share his thoughts with us today. Very much appreciate your being here, Harvey. Again, we are indebted to you for all your service to the society, and we will be even more indebted after hearing your thoughts today at this important time in the response to the COVID pandemic. I'll turn it over to you.
Thank you so much, Kathy. Good morning to you. I want to thank you and Drs. Prosser and Sandra Schmidler for inviting me directly to participate in today's session. And I want to add my thanks to Drs. Schwartz and Meltzer for organizing this important conference. The theme for my opening comments this morning is decision-making in a global pandemic. Modeling matters. When I thought about this topic, it brought to mind an experience when I was a medical intern working in the emergency room. And one night, in the middle of the night, writing up a patient I had just admitted in the ER, there was a surgical resident sitting across from me in the residence room, also writing notes for a patient that he had just admitted. At one point, he looked up at me and he said, "I've just had a revelation." And sort of sleepily, I glanced up and said, "What's that?" He said, "Do you realize every single person on the planet is either op, pre-op, or post-op?" So I thought about that in connection with today's program, because really it's not so far, that surgical mindset, from thinking that the world is either in the midst of COVID, was pre-COVID, or will become post-COVID at some point in the future. Today, in October of 2020, many more than 10 weeks after I wrote the article that Kathy alluded to, we are squarely in the midst of the COVID pandemic, definitely in the time of COVID. This pandemic, in a way, is both a surprise and utterly anticipatable. Emerging infections as a class have been recurring for decades that we have recorded. And just in the space of the last 20 years, we had SARS the first, we had MERS a decade later, both coronaviruses. We had the 2009 H1N1 influenza pandemic, we had Zika, we had Ebola, and now, of course, we have SARS-CoV-2 and COVID. What characterizes all of these is that they are zoonotic transmissions. They emerge into the human population from animals. Most of the time, zoonoses do not transmit efficiently from one human to another. Many of us will recall the avian flu scare in early part of this century. So most of those zoonoses are not serious ongoing problems. But for us, SARS and SARS-CoV-2 were quite serious. The first SARS was not as efficiently transmitted. It did produce much higher mortality. It was about 1 in 10 of those with clinical conditions did die from the original SARS. But the current SARS, for purpose of thinking about modeling, has a number of very distinctive epidemiologic attributes. First is, of course, its relatively high transmissibility. Secondly, and as we're learning, particularly from a very important study just released this week in Science, the virus is transmitted typically by a relatively small number of relatively high emitters of the virus. In the study in India, for example, more than 70% of those infected did not actually transmit to any of their contacts. A third feature of this virus is the remarkably wide spectrum of clinical expression, where 40% or more will be utterly asymptomatic throughout the course of their illness. Others will get sick, and yet others will be fatal conditions. And the spectrum is very dependent on underlying conditions, including a remarkable age relationship. This disease is capable of being transmitted during the asymptomatic stage, and that puts it in a very special and challenging category. And finally, it's clearly global in scope, but its expression, not only in different parts of a country as large as the United States, but from country to country, is extraordinarily variable in the way in which it has created and presented as a serious problem. In any given day in the United States, for example, now we might have as many as 150 new cases on average. In Japan, the number will be more like 5. So it introduces, for the purpose of understanding and trying to model, many challenges about the differential expression, epidemiology, clinical course, and of course, strategies to contain and contend. COVID is really multiple crises rolled up in one. It's a personal medical crisis. It's a public health crisis. It has been a clinical care crisis. It is an ongoing economic crisis, and it's also a social crisis, exposing and exacerbating disparities in health and striking at public confidence. And finally, it also raises critical challenges for international relations as a global problem that really cannot be solved anywhere until it is solved everywhere. So thinking about it analytically, we could characterize COVID-19 in a number of pertinent ways. First, the severity of this disease has elevated its visibility and brought to the fore many interests from groups, scientists, academics, businesses, and others that were not working on viruses, much less on COVID, But at the present time, there are more than 700 prospective treatments, vaccines, and other interventions under development and being tested in various ways. Secondly, because it's an emerging disease, even though as a coronavirus, it may share certain attributes with previous coronavirus outbreaks, it is a distinctive novel entity. So we haven't seen anything exactly like it before. Therefore, it introduces heightened uncertainty about its clinical and epidemiologic expression, its amenability to various interventions. For example, it was very uncertain the degree to which the summer months might bring a degree of respite from the virus. And now, as we're facing the winter, questions about the emergence of additional cases, potentially in conjunction with other respiratory viruses that have a seasonal character, particularly influenza, but also adenoviruses and others. Third, the coronavirus COVID pandemic is a highly complex entity. It has many, many parts and many different relations among these parts, some tightly coupled, some loosely coupled, some relations that are dampening, some that are amplifying in the circuit sense. These multiple interacting and interdependent spheres, from the viral sphere to the human sphere to the social and institutional spheres, these create many challenges for adequately modeling the events and circumstances that we want to consider. The multiplicity of actors and decision makers involved also complicates the problem. And there are multiple loci for decision making at a local, state, and national level in the United States, at the international level, for individuals, for the community, for institutions, for healthcare systems. All of these are important settings for critical decisions and modeling related to COVID. And finally, we cannot emphasize enough the dynamic nature of the circumstances that apply to COVID. The rapidly evolving expression of the disease in different parts of the world, the emergence of new knowledge about the virus, about the disease, the advent of new technologies to contain or treat or manage in different ways for purposes of prevention or treatment or diagnosis. All of these add to the complexity of modeling. And if you consider the special case of the United States, we can add additional layers of complication, including at a public health and cultural level, a set of values and mores that puts a strong emphasis on individual liberty and relatively less emphasis on collective welfare. Contrast, for example, a culture such as in Japan, where anyone who would not be wearing a mask would feel humiliated if anyone else became sick because of their neglect. Secondly, importantly for policymaking, the United States federal system, in which we have never, from the founding of the Republic, fully resolved the issues of federalism and sovereignty among the states and the federal government, during a crisis produces a number of added tensions, uncertainties, and complications in dealing coherently and consistently with the pandemic. And finally, of course, this is an election year in the United States. The political overtone to the pandemic is yet a further complication in dealing effectively with the outbreaks, with the pandemic, with the problems that arise in the tensions between the federal and state governments, for example. I can recall well back in the 1970s during the last effort to deal with a pandemic to immunize the entire US population against the threat of what was then perceived as a swine influenza potential pandemic. It was also an election year, and some people were also suspicious of decision-making by then President Gerald Ford because of the fact that it was an election time. But that is nothing compared to the experience that we are facing today. Modeling as an approach to coping with a pandemic from an analytic, systematic point of view offers a number of advantages when trying to come to grips with a situation that is as urgent, complex, dynamic, multifaceted, and fraught as COVID-19. Let me just mention 5 critical features of modeling. First, they represent a systematic way for analysts to bring the knowledge and understanding of scientists, clinicians, public health professionals, and other experts to bear directly on the questions and decisions that decision makers, policymakers, clinicians, the public health leaders are all facing. Secondly, modeling can be a basis for assessment that provides a ready means of communication and understanding across analytic and policymaking spheres. It's a tool that fits in a much larger context of the relations between experts and policymakers, science, and government officials, a much larger topic, but modeling is a critical tool in that relationship. Third, modeling in a complex situation, such as the COVID-19 pandemic, is a way to systematically characterize all the relevant elements and relationships that determine the course of events in the real world. Fourth, models allow an analyst and a decision maker to focus on any one key part of the problem without losing sight of the whole and without missing out on the key interdependencies that will affect the decision. And finally, properly constructed, models enable an analyst and a decision maker to incorporate dynamic elements as new understanding, new scientific discovery, new knowledge, new technologies, new strategies all emerge. In other words, modeling can be a very flexible tool to provide a sophisticated approach to comparing and choosing. Now, COVID has raised and continues to raise, as David alluded, a plethora of questions and challenges that are amenable to modeling. Just to indicate a few, the fundamental tracking and projecting the course of the pandemic, gauging the impact of the variety of possible combinations of public health interventions and other practices to contain the virus, trying to trace the relations among economic consequences and medical public health consequences, the dual crises of this pandemic. Thinking about optimal strategies that would apply to individual patients, apply to a community at risk, apply to a particular work site or school setting, all relevant. Examining the special role of social inequities and the differential burden of disease on different parts of the population. Projecting for this winter and beyond the combined effects of the COVID pandemic with the possible overlay of influenza adenovirus, and other winter respiratory viruses. And very importantly, thinking through the optimal sequencing stratification of vaccine candidates. Once a vaccine becomes available, that sequencing and application in a smart way can make a huge difference in the rate of spread and capacity to cope with the pandemic. For all of these challenging reasons, for all of the advantages that modeling brings, we're part of the thinking at the Gordon and Betty Moore Foundation when we chose to sponsor a series of COVID modeling efforts, a number of which will serve as a backdrop for your discussions through the course of the day. As a general observation, modeling serves one of three overarching purposes. First, it can be descriptive, primarily a way to express what the situation is, highlighting key aspects, particularly in the course of tracking and monitoring. Secondly, a model can be predictive. A model would estimate future variables of interest, outcomes that we care about, whether it's hospitalizations, deaths, numbers of cases, numbers who become immune, all based on the relevant inputs and predicated relationships. And third, and most importantly for us in the Society of Medical Decision Making, models provide decision support. They can be used to compare different choice scenarios in terms of the projected effects and their bearing on the desired outcomes. In practice, many models actually combine elements of the descriptive, the predictive, and the decision support. I'd like to just briefly identify 8 dimensions of modeling that may be useful to keep in mind through the course of the day of thinking and discussing the various models and how they apply, what their advantages and potential limitations are. I group these under the categories of structure, purpose, outcomes, methods, data, uncertainty, updatability, and reproducibility. These 8 attributes relate to the usefulness, the clarity, the relevance, the timeliness, and the reliability of models as aids to decision making. Just a word on each. Structure. Every model is a simplification. It entails choices about what to include and what to omit. Underlying assumptions are always key. Are they exposed? Did the modeler incorporate key components in a sensible way? Are any essential pieces for the purpose of that model left out? And is there a good balance between comprehensiveness and comprehensibility? In other words, is it sufficiently complete and still understandable? Secondly, purpose, the suitability and clarity of the purpose. Is the purpose of the model clear? Is it well laid out? Does it serve the intended role for aid in decision making? Third, outcomes. Did the modeler choose the outcomes of greatest interest and relevance to the decision maker? Fourth, on methods, are the choices of methods and modeling technique well suited to the purpose and the circumstances? And has the modeling exercise itself technically been executed proficiently? Data. Have the most appropriate, accurate, current data been incorporated into the model? Coping with uncertainty. Have the uncertainties, both in the assumptions and in the data, as well as in the relationships, been specified? Have the results been quantified in a probabilistic way so that one can understand the range of probability associated with any projection related to the model, and are the influential factors, those elements that make the most difference to resolving the uncertainty, have they been properly identified? Updatability. In light of the dynamics of a situation such as COVID, in knowledge, in technology, in discovery, is the model capable of being updated and in a time frame that is still relevant to the decision maker? And finally, reproducibility. Reproducibility, when it comes to modeling, involves both code and data. Has the analyst made code and data available so that others using the same inputs can obtain the same results? Reproducibility with replicability are two of the key hallmarks of science that affects the reliability. All of these elements, these 8 elements, contribute to the usefulness, the clarity, the relevance, the timeliness, and the reliability of the modeling exercise. In conclusion, I just want to bring to mind a remark of one of the titans of biostatistics of the last century, Fred Mosteller. Professor Mosteller once observed, "It is easy to lie with statistics. It is even easier to lie without them." And in that spirit, I think we might say it is easy to make mistakes based on models. It is even easier to make mistakes without them. Our hope is that the models that you and many others are crafting will contribute to deeper understanding, new insights, and better choices in the time of COVID. And looking beyond to the post-COVID era, we can hope that the spirit of scientific collaboration, open exchange, and cooperation amongst all of the analytic community and the scientific community can be sustained in a way that helps us solve not just future pandemics, but future challenges for health and for society. Thank you so much for the privilege of being with you this morning. I wish you wonderful discussions through the course of the day, and look forward especially to keeping in touch with the modeling successes that emerge from your work today and beyond. Thank you very much.